for logging on to our World Sleep Day chat. I just need to make everyone aware that the meeting is being recorded, so I hope that's okay with everyone. If I introduce myself, my name is Dot Price and I'm one of the staff governors here at Liverpool Heart and Chest, and I also happen to be the manager of the respiratory diagnostic department here at Liverpool Heart and Chest. There's a slideshow which we'll endeavour to share the screen. I'm going to be slide operator, and Jenny, who's my deputy and the advanced practitioner for sleep, is going to do the talk, and I'm going to be a little sidekick. Apologies now if technology gets the better of us, but hopefully, fingers crossed. And there'll also be a chance at the end of the presentation for any questions and answers. So there's just a couple of slides that I've got to go through first. So I'm going to attempt to share my screen, so just bear with me. So can everybody see that screen? I take it that unless someone says no, I take it that you can see, because I can't actually see you all now.
Yes, Dot.
Thanks, Trevor.
Yeah, it's
so
coming through fine.
Sorry?
It's coming through fine.
Okay, that's great. Thank you very much indeed. So as I said, welcome to our presentation on sleep. So I am attempting now to move to the next slide. So just again, we're all a bit used to Microsoft Teams now, but if I could just please ask that to avoid sort of feedback and things and background noise, if you're not talking, if you could put your microphone on mute. And what we're saying is you don't have to use your camera. So by all means, put your camera on if you want to, but you don't have to. And again, we know that there are some distractions and things, but if you could disable your microphone and your camera, if you have to get up or you get called away, that would be great. As I said, there is a designated question and answer session at the end. And if you can, raise your hand. Now, if I stop sharing my window, I should be able to see, but Jenny should be able to see who's raised their hands as well. Failing all of that, just shout out, but we'll try and avoid that if we can. And then if you can wait to ask until we've, each delegate has finished speaking, that would be great as well. You can also use the chat function and you'll see a little speech bubble somewhere on the screen. And if you click on that, you can type a question. And again, we'll endeavour to answer all the questions. And then if you happen to lose connectivity, you can just sort of log on again and follow the same link as before. So this is one of our members events. And what we, again, endeavour to do at LHCH, whenever we do these things, is to encourage members of the public to become members of LHCH Foundation Trust. And people might ask the question, why? What's the point? Why would you bother? And we've tried to list the things that are relevant here, and we try very hard, and obviously during COVID, it's sort of dampened down our events and things. But we try to put on these health awareness events, talks throughout the whole year, and there's usually a good variety. And we've adapted, because this is I think the second one we've done online. And it is a bit weird to get used to rather than face-to-face, but what we hope is that it helps keep LHCH in the picture, so people know what we're about and the work that we do here. You would receive copies of our Members Matters newsletter, which, LHCH is an extremely important part of the local community and beyond. So it's about get involved, come and see what we do. If you're a member, you can vote in governor elections, because there are public governors, and one or two of the public governors I know are on the event. And then eventually you're eligible to stand for the role of the governor. So if you want to be part and parcel of the next few years in helping shape healthcare for your local community, be a member, become a governor. And there's opportunities as well to join focus groups for all sorts of different things and have your say. Very easy to join. The registration is free and you do it via the LHCH membership. And come and join us. We do some great work. Jenny and I have been around a long time. And so we just love LHCH, but we're a bit biased. But you know, the public governors are around as well. So if you've got any good questions you want to ask the governors, I'll rope them in as well at the end. So that's it. Let me just, so if I can introduce Jenny, who is my deputy. She's our advanced clinical physiologist for the sleep service, and she's our lead healthcare scientist at the trust. And I'm going to, as I said, I'm going to be a slide operator. So please just bear with us if we go a bit wrong. Thanks.
Thank you, Dot. And Dot calls herself my sidekick, but I'm actually sort of Dot's protege. So Dot used to run the sleep service before I did. And so I will be relying on Dot at the end for the question and answers to dip in and help me, if that's all right, Dot.
Fine, Jen.
So I've put a little talk together about sleep apnea. So mainly focusing on how we diagnose sleep apnea and how we treat sleep apnea. Next slide, please, Dot. So the first thing to think about is, what is sleep? Previously, up until around about the 1950s, 1960s, everybody, sort of the general consensus in science was that sleep was dormant, passive, nothing happened in sleep, we just slept. With the advancement of devices such as EEGs, which can measure brain activity, we quickly learned that sleep is definitely not dormant, it's not a passive activity at all, and that our brains are very much active during sleep. I used the quotation there from Karskeden and Dement, and they say that it's a reversible state of disengagement from and unresponsiveness to the environment, which is true. We can come back from that disengagement, so we wake up in the morning. But I think that kind of gives the impression that not much happens during sleep, when, like I say, as we've found out recently, it definitely does. Next slide, please, Dot. So sleeping. So like I say, since the 1950s, since this sort of advancement with diagnostics and devices to measure brain activity, we do know more about sleep than we ever did. But saying that, we don't really know much about it at all. So it's very much uncharted territory, sort of sleep science and sleep investigations. Next slide, Dot. So thinking about why we sleep and why we need sleep. We process things during sleep. Sleep allows for restoration, so we can rest, relax, recuperate, rebuild. We solidify our memories during sleep. So studies have shown that sleep's very important in sort of solidifying those long-term memories. So we take our short-term memories, things we've encountered during the day, and we solidify them, we process them, and we put them into storage, so to speak, into our long-term memory, and that occurs during sleep. And sleep's also important for sort of physical regeneration as well, so repair, growth, a lot of hormone activity takes place during sleep. And as these processes occur, if for any reason we disturb or fragment our sleep, that can make a big difference to how these processes do happen whilst we are asleep. And next slide, Dot. So just a few sort of examples here, thinking about if we have a lack of sleep or we have fragmented or poor quality sleep, that's when problems can occur, and that's when we start to get into the territory of sleep disorders. And next slide, Dot. So there are lots and lots and lots of sleep disorders. So the ICSD, the International Classification of Sleep Disorders, and they're a group that have identified over 80 different types of sleep disorders, and they've roughly placed them into 6 categories. So there's insomnia, which is the inability to sleep. I can't sleep. There's sleep-related breathing disorders. So things that happen with our breathing whilst we are asleep. And the main one is what we're going to talk about today is obstructive sleep apnea. There's then disorders of hypersomnolence, which is things like narcolepsy. There's circadian rhythm, sleep-wake disorders, which are our body clock. So things that affect our body clock, so things like jet lag. Parasomnias is the sleep talking, sleepwalking, night terrors, that kind of thing. Sleep-related movement disorders is your restless leg syndrome. And then, as always, with any sort of scientific group, there's other, which is the weird and wonderful things that people have found that are quite rare that they can't quite put into one of those 6 groups. So there's always that other category. So like I say, I'm going to talk mainly about obstructive sleep apnea this afternoon. Symptoms of sleep apnea, broadly, we tend to think of the triad of symptoms. So the 3 main symptoms of snoring, feeling tired during the day, and apneas. And an apnea is a pause in your breathing. That's all an apnea means. The main problem we have is that if you have sleep apnea, it can affect your daytime functioning. So that symptom 3 of daytime sleepiness can affect driving, it can affect employment and things like that. Next slide, Doc. So as well as the 3 main symptoms, there's 100 other symptoms that patients describe when they come in and we think that they're going to have a diagnosis of sleep apnea. Headaches, irritability, quite often depression or restlessness in general during the day as well as at night, frequent trips to the bathroom, nodding off during the day, so unplanned naps, falling asleep when you don't need to or want to. And a lot of patients will come in with a variety of these symptoms. And next slide, Doc. So I was going to show you a quick video here of what obstructive sleep apnea looks like, but we've got a few gremlins in the system and the video's not working. So I'll try and describe sleep apnea to you. And the way I tend to describe it in clinic is if you picture your airway as being a tube of muscle, so a nice round open tube of muscle. Muscle relaxes when we fall asleep. So our airway can relax, it can get a bit floppy, it can vibrate, which is snore. And every now and then in all of us, that airway will either close, so your breathing stops for a short time, or the airway will narrow, so your breathing is very shallow for a short time. The most important thing to remember is whichever one of those it does, whether it closes or narrows, it always opens again because the body wants to breathe. So the body will do a little bit more work than it normally does in sleep, but it will eventually open that airway, and it will open it with a snore or a snort or a gasp, and that breathing will return to normal. But eventually that airway will get a little bit floppy again and it will close or narrow again. So that's kind of what sleep apnea is. It's an upper airway. So we're looking at sort of around the region of the voice box, back of the tongue, that type of area rather than lower airway. What OSA sounds like, and again, the gremlins are in the system, is you tend to get some quite loud snoring. And that's when we're doing our breathing in and out because our airway's floppy and it's waggling about a little bit. We then get that pause. So that airway closes and we get that pause. We have to have a pause of around about 10 seconds for us to count it as anything significant. What then happens is due to a build-up of pressure, that airway suddenly opens again. We get what we call a recovery breath. So a big, deep breath, sometimes quite loud. It's got a snore associated with it, and our breathing starts again. The size of the problem in relation to obstructive sleep apnea, really, we don't know. How many people go to the doctor because they feel tired it's difficult to say. I think a lot of people put up with tiredness. Tiredness can become the norm for people. That's just how they feel. People often have 100 things going on, you know, children, work, hobbies, they're busy, grandchildren, that kind of thing. British Lung Foundation thinks that probably about 1.5 million people in the UK have sleep apnea, but a large proportion of those are not diagnosed and so therefore not treated. Not all the time, but sleep apnea is often related to obesity. So quite often sleep apnea is weight related. There are exceptions to the rule. Other things that can cause sleep apnea that aren't as common are things like receding jawline, particularly large tonsils, that kind of thing. Obviously, one of the most common things is obesity. So as incidence of obesity rises, sort of UK and worldwide, sleep apnea is only going to become a bigger problem. So diagnosis and treatment. So I'm going to talk a little bit about how we diagnose sleep apnea. So we do a sleep study. And then I'm also going to talk about treatment, the main treatment being CPAP, which I'll talk about. And then there's also a few other things that people can try in addition to CPAP treatment or instead of. Next slide, Dot. And just to quickly show you the rise of sleep apnea just here at LHCH. So just before COVID hit, so 2019, 2020, we did just under 1,000 sleep studies that year. And it was rising substantially until then. We had a little dip during COVID, but we didn't stop. We still did over 500 studies last year. And we're probably on track to be not too far off our biggest year this year as we go through sort of the COVID recovery phase. So diagnosing sleep studies, there's lots of different types of sleep equipment that you can use to diagnose sleep. So you can have very basic bits of kit which sit on your wrist like a wristwatch, and they look at your oxygen levels, through to coming in as an inpatient and having a full EEG, ECG and all the other bits and bobs. At Liverpool Heart and Chest and at a lot of trusts, we tend to go for a bit of a halfway house. So this is called a limited respiratory study. We use a system called NOx T3. And what we look at is airflow. So we have some cannula to look at how much air you're breathing in and out, and obviously looking for that pause in your breathing if you're having apneas. We look at the effort it takes to breathe. So a patient will have a couple of chest bands around them, and as you breathe in and out, we're looking at that effort you make to breathe. We're also looking at your oxygen levels, which we do via a wristwatch, and we monitor the pulse in your finger as well, which gives us an idea of your heart rate. So what we're looking at is any pauses in your breathing, and then alongside that, do your oxygen levels change with that pause in breathing? So the number of apneas that you have determines if you do have sleep apnea, and if so, how severe that sleep apnea is. So like I said, everybody, a little bit through the night, that airway will close or narrow and it will open again. It's normal, and it'll happen in nearly all of us. How many times an hour it happens is the most important thing. And I've listed here, if it happens less than 5 times an hour, it's normal. And then anything over 5 times an hour, we can diagnose as mild, moderate, or severe sleep apnea, depending on the number. Our record here, I think we just did the other day, was about 140 per hour. Somebody was either stopping breathing or the breathing was very shallow. So a lot. I think probably not breathing more than breathing whilst they were asleep that night. Next slide, Dot. So this is an example of what we look at. So when we get the equipment back from you the following morning and we download it, we have a little look at your sleep study. This is 5 minutes of a 10-hour sleep study. And what we're looking at here, that very top line with the green is your oxygen levels. We've then got your heart rate just underneath that. The third line with the big blue waves is your airflow. So that's you breathing in and out nice and steady. And the red and green lines underneath are the effort that you're making to breathe. And this 5 minutes is completely normal. So we've got some lovely airflow, we've got some lovely deep breaths back and forth. And mirroring that, we've got some nice effort to go along with it. So those red and green bars are almost mirroring the flow. So that's a lovely, nice, normal sleep study and a nice normal pattern of sleep. And then the next one, Dot. So this one isn't normal. This is sleep apnea. So if you have a look at that top line, which was the oxygen levels, the green boxes that we've put in are what we call desaturations. So oxygen level is dropping. If we look down at the flow, which is the third line down where the orange boxes are, can you see that we've got that flow? Got a couple of breaths in and out, and then we've got a straight line and the breathing has stopped. So the airway is closed over and the breathing has stopped. If we have a look at the green and red lines underneath, which is our effort, we're still trying to breathe. So our body wants to breathe. So the effort's reduced a little bit, but we're trying. And what eventually happens is that airway unblocks and we get that lovely big recovery breath that you can see there as well. So that's 5 minutes and the patient has stopped breathing 1, 2, 3, 4, 5, 6, 7 times just in that 5 minute epoch there that we're looking at. So this will be quite severe sleep apnea. And again, the next slide Doc's just flipped to is a similar thing, just a different patient here. If you have a look at the bottom line that's blue, that's snore. So if you look at them together, you've got patient stops breathing, which is our orange box. We've got our flat line. We go up a little bit and we can see their oxygen levels have dropped a little bit, which is our green box. And if we look down near the very bottom, we can see that they do a lovely big snore and their airway opens again. And that will be a repeating pattern through the night in a patient with obstructive sleep apnea. Next slide, Doc. This is what we call a hypopnea. So if you remember, I said the airway can close or it can become very narrow. When it becomes very narrow, we call that a hypopnea. And you can see in the blue box, the patient is still breathing. There is still some airflow there, but it's very, very shallow. And again, we count that as the same thing and we look for how many times an hour either one of those events occur. So a closure or a narrowing of the airway. Next slide, Doc. And then this is the whole night together. So this is a whole night's trace of a positive sleep study. So this patient stopped breathing or breathed shallowly just over 80 times an hour, which is severe obstructive sleep apnea. And what we've got is lots of lines everywhere. So the orange, it looks almost like a bar, but it's actually individual lines. That's the actual events that are occurring. The green, again, it looks like a bar. That's individual oxygen changes. And then the blue bar towards the bottom is snoring. So they were having apneas, their oxygen levels were changing, and they were snoring for nearly the whole night. So very, very positive sleep study, that one. Next slide, Doc. So the question once you diagnose sleep apnea is how does that affect you during the day? So we can do a sleep study, patient can take some equipment home, wear it overnight, we download and report it and they have sleep apnea. We physically measured that. We've got a score, how many times they stop breathing, and we know they have sleep apnea. Treatment then depends on how that makes a patient feel during the day. And there are broadly 2 types of sleep apnea with and sleep apnea without the associated syndrome. And the associated syndrome is that daytime sleepiness. Is sleep apnea making a patient sleepy during the day? And there's no real hard and fast rule as to whether it will or won't. You can have patients with very severe sleep apnea, like the one we've just seen, and they might feel absolutely fine during the day, not sleepy, not nodding off, and probably the reason they've come to clinic is that their partner says they snore. Opposite end of the scale, you can have patients with very mild sleep apnea who feel horrendous. They feel very, very tired, they're nodding off in work, feel unsafe to drive because they feel that sleepy during the day. So what we need to do is try and think of a way that we can measure that sleepiness. Now, it's really hard to do because sleepiness is very subjective, and how one person might feel, another person might not think that is particularly sleepy at all. But there are different questionnaires that have been devised to try and put a number on sleepiness, to try and measure it. And the one we use is the Epworth sleepiness scale. So as you can see on the slide, it's a few questions, and we ask you to rate how likely you are to doze off in each of those different situations. Now, if you answered 3 for all of them, a high chance of dozing, then your maximum score is 24. As a rule of thumb, any score over 10 suggests that you're excessively sleepy during the day. So sleepy beyond the norm, so beyond a busy day. You're more tired than you should be, if that makes sense. And we use this as a guide. We use it in relation to a clinical consultation. We would never use this as a you are or you aren't sleepy. It's a useful tool. But what's more important is talking to the patient, asking them questions about how they feel, bedtimes, do they nod off during the day, do they feel they need a nap in the afternoon, that kind of thing. So it's useful, but it's not the be all and end all. Next slide, Doc. And then just talking about the implications of sleep apnea with the syndrome. Obviously, there's the effects of the daytime sleepiness and what that means in terms of, can you drive, your mental health and well-being. There's nothing worse than trying to make decisions, trying to function on really poor quality sleep. It affects everything. It affects your decision making, it affects how you feel, your emotions. And there's also quite a few studies that have shown relationships. There's been no real studies that have said one disease causes another in terms of sleep apnea, but there's been a lot of studies that show there are relationships between having undiagnosed, untreated sleep apnea syndrome and things like high blood pressure, diabetes, cardiovascular disease, risk of stroke. Like I say, nothing's really been proved to cause another, but there are often links between the two. Next slide, Doc. And just to touch on road safety, because I think when a lot of our patients come for a sleep study, driving is one of their main concerns. Can I drive with sleep apnea? One of my answers tends to be, whether you have sleep apnea or not, you should not drive when you feel sleepy, and that's the law. And as it says there, 62% of all adults have reported driving when they feel tired, and it's difficult, you know. It can be sleep apnea, it can be a night up with the children, it can be the dog was barking, you know, it's hard to say that we haven't driven when we're tired as a group of people. But the clipping that Dot and I always use is the one of the young couple whose car was hit by a lorry driver who had sleep apnea, and I don't think was particularly compliant with his treatment. And had what we call a micro sleep. So he literally eyes closed for a short second and he nodded off at the wheel. Next slide, Dot, please. And then they look a bit dramatic, these pictures, but it's just to highlight that sleep apnea has been proven to be the cause of quite a few road, rail, shipping disasters. And when I refer to micro sleeps, literally it can just be half a second that you've closed your eyes for. An untreated sleep apnea syndrome is really, really sort of dangerous if you're a driver. We have a lot of patients who are HGV drivers, bus drivers, we've had taxi drivers in the past, and the key is to be getting on treatment and to be compliant with treatment. And this is an example of the effects when that doesn't occur. Next slide, Doc. And then this is the one that appears in most sleep talks. So this is, I think it's an American website that this is taken from. This chap retired because he was falling asleep all the time in work. When he eventually retired and he went and saw his GP, he was diagnosed with sleep apnea. He was treated with CPAP and his symptoms of daytime sleepiness resolved. So this is sort of an example of how socially this can have an impact on people. It's not just a case of treating people from a health perspective, it's also treating them in terms of social skills, economic. It's a big impact if you have untreated sleep apnea, and this chap was sadly forced to retire early. Next slide, Doc. Like I say, driving is one of the things that people worry about most if they're facing a sleep apnea diagnosis. Falling asleep at the wheel tends to account for about 1/5 of road traffic accidents. Somebody with untreated sleep apnea has similar reaction times to people who are over the drink driving limit. And around 300 road traffic accidents per year, sleep apnea is seen to be a contributing factor. And again, just another fact down the bottom, you're about 7 times more at risk of a road accident if you have untreated sleep apnea syndrome. Lorry drivers is always a main concern with sleep apnea. There are around 500,000 lorry drivers in the UK. Around 1/4 of those would have a BMI that puts them into the obese category. And we think around 1 in 6 probably have sleep apnea. Again, probably most of them are undiagnosed. And falling asleep at the wheel is the most common single cause of a truck driver being killed at work or killing or injuring other road users. And then just sort of a few facts that hit home really. 40-ton truck traveling at 56 miles an hour will crush at least the first car and its occupants if it hits a queue of stationary vehicles. If it collides with the central barrier, that central barrier usually collapses and the truck will likely career into the opposite carriageway. So I know a lot of haulage companies have started to take sleep apnea quite seriously, and I think it's become part of medicals for quite a lot of haulage firms. They will at least screen people in terms of sleepiness with a questionnaire like the Epworth questionnaire. The next two slides I've just put up really for interest. DVLA insist that people with sleep apnea syndrome are adequately treated for that daytime sleepiness before they are allowed to continue to drive. Group 1 drivers, so your car and motorcycle drivers, whether their sleep apnea is mild, moderate or severe, they shouldn't drive if that sleepiness is not controlled, and they are likely to be monitored. Your Group 2 drivers, so your bus, lorry and taxi drivers, monitoring is essential, and DVLA will ask hospital trusts to review their patients who are these types of drivers and ensure that they're compliant with their CPAP treatment in order for them to continue to drive. Next slide. And this is just an example of one of the leaflets that we give out when we issue our sleep equipment. So we give a DVLA leaflet out which talks about tiredness. And we always say, regardless of OSA, you shouldn't drive if you're sleepy. That's the main take home for drivers. Next slide. So if we've diagnosed someone and we've sort of come to a conclusion between us, so between us and the patient, that they are excessively sleepy in the day, and we've diagnosed them with sleep apnea and the syndrome, then it's what we do, it's how we treat a patient. NICE guidelines, who we follow, recommend CPAP for nearly all patients who have moderate or severe sleep apnea and sleepiness. A CPAP machine is a small machine, about half the size of a shoebox. It sits by the bedside, and off that machine, there we go, is a tube and a mask. You wear the mask when you go to bed, and what that mask does, what that machine does, is it takes in room air, it filters it, and it pressurizes it slightly. So it's not giving you any extra oxygen, it's not doing the work of breathing for you. It just means that you're breathing in room air at a higher pressure than normal. And the idea of that is that that acts as a splint almost, and it keeps your airway open. We can't physically put anything into your airway, but we can use that column of air to keep the airway open. If we keep it open, it doesn't collapse, you don't have the apneas, and your sleep isn't fragmented. If you think about it, each time you're having one of these apneas, your body has to do more work than it should. And a consequence of that is that you tend to come from a deep sleep to a much lighter sleep. If you're having 80 of these an hour, then each time your airway opens, you haven't got that much time to get back into the deep sleep before you have another apnea. And so your sleep is very much fragmented and you don't get a lot of deep sleep. And it's the deep sleep where restoration, rest, recovery, growth occurs. So if we can keep that airway open and stop those apneas, you can get that quality sleep that you need. Next slide, Doc. So what makes an ideal CPAP service? Main thing would be, in an ideal world, a patient would get their treatment as soon as they're diagnosed. If we've got a HGV driver or a taxi driver, or even a mum who needs to take the children to school because the school's 10 miles away, what they need to be able to do is carry on doing what they're doing without any break. So in an ideal world, you would have a sleep study. You would see somebody about that sleep study, so a practitioner or a consultant. They would give you the results, and if it's positive, you would have a CPAP machine the same day. That way you can go home, you can get used to your CPAP, you're on treatment straight away, and things like DVLA become much easier to navigate because you're diagnosed, but you're on your treatment. Your symptomatic benefits are instantaneous if we can give you a CPAP machine straight away. It's safer for everybody else because if you're going to continue to drive, your treatment's optimized and you're on CPAP. It allays anxiety, like I say, people who drive for a living, people who need their cars to get from place to place, also people who are anxious because they have other health conditions. So patients who are diabetic or patients who have COPD or heart failure, they know, they've done some reading and they know there's links between these illnesses and OSA. So if we can get patients on treatment quicker, it allays anxieties there as well. Next slide, Doc. We're near the end, that was quick. So this is just, we did a patient survey of our own CPAP patients just before COVID. And these are some of the comments that we got on our in-house questionnaires. And most of them are concerning quality of life. I think, you know, patients felt better. We have a lot of patients who say, didn't realize quite how tired I was until I started to feel better. And like I say, that goes back to, we're all busy and tiredness kind of becomes a norm for a lot of us. We kind of think that that's how we should feel, that's how everybody else feels. And so it's encouraging people to go to the GP if they do feel tired, and especially if they have any of the other symptoms as well. You know, if they are snorers, if someone's ever said to them, sounds like you hold your breath sometimes when you're asleep, or, you know, if they find themselves waking up 2 or 3 times a night to nip to the bathroom, anything like that, we would always encourage people to see their GP, because something like sleep apnea is very easily treated, but does play havoc on your life if you leave it untreated. So the take-home message would be, people, please see your GP. Tiredness isn't something you should put up with. There might be an underlying reason for it. And I think that might be it. Is that the end of the show?
That is the end of the show, Jen. Thank you very much. And thanks very much for that. Now, I know a lot of this, but I enjoyed it. So, so I hope we haven't knocked anyone off to sleep. But I'm just going to get rid of the slideshow on my other screen, and we're going to try and answer any questions. Oh, Trevor, you've got your hand up.
Yeah, thanks very much, Jenny. Very, very interesting presentation there, particularly comments about driving. But my question is associated with studies. You've done an awful lot of studies, particularly pre-COVID. But has that revealed anything to enable you to either have a different or a better treatment for sleep apnea?
There's not really much better than CPAP. Other treatment options, didn't really talk about them, did I? So other treatment options for CPAP tend to be either surgical, so ears, nose and throat team. They also tend to be mandibular advancement devices, so gum shields, sort of specific gum shields, but they're really for a specific type of patient with sleep apnea. So if you had a patient who, for example, was very slim, but had a very receding jawline, then you may look down the gum shield type treatment rather than CPAP. So what you would be looking for there is something to bring that jaw forward. And so you would probably be in touch with your dentist to see if there's anything that they can tailor make you that you would sleep in at night. And what they do slowly over time is just bring that receding jawline forward. And by bringing that forward, the idea is that you uncrowd the airway at the back. So a receding jawline can push everything back and make that upper airway crowded. Surgery, if we thought that your sleep apnea was caused by huge tonsils and nothing else, then again, surgery might be useful. We did have a patient a long time ago, do you remember, Dot, who had a combination of obesity and huge tonsils, and she was on CPAP. She lost a lot of weight. She was referred for surgery. She had her tonsils out, and I think it was a combination of the two with her weight loss and surgery, and she was able to come off CPAP. She'd sorted herself out, she cured herself with weight loss, and obviously that surgical intervention as well, because she had the large tonsils. The problem with surgery is that sleep apnea can come back. The problem with that is that CPAP apparently is much harder to tolerate if you've had ENT surgery in the past. I think it can make it more uncomfortable. Am I right, Doc?
Yep, spot on,
So
Jen.
it can make tolerating CPAP, if you ever needed it in the future, more difficult. I think sometimes people think surgery is the permanent solution, but it's not always, it doesn't always work. So we'd always advocate CPAP first because it's non-invasive, and there's nothing ventured, nothing gained really with CPAP. It's not going to damage your airways, it's not going to cause pain or distress or anything. You would either feel better from it or you wouldn't. So we'd always try CPAP first, I think.
Okay.